Hi, I'd like to welcome everybody to another edition of MD Insights. I'm delighted to be here today with Dr. David Kwon, who is our Director of Laparoscopic Liver Surgery at Cleveland Clinic. David, welcome. Thanks for spending time with me today.
Thank you for the kind invitation.
So tell me, what made you want to grow up and be a laparoscopic liver surgeon? Tell us a little bit of the background and the route you took.
Well, yeah, I initially started with liver transplant. So my training background is purely based on HBV oncology and liver transplant. So that's how I started my career. And I've been doing I was in a very high volume institution, and I was doing a lot of that. And around 2008, I was attending some conferences, and it seemed like the field of laparoscopic liver surgery was moving in a relatively very fast speed into minimally invasive. Until 2008, I would say that minimally invasive liver surgery overall was still struggling, trying to do major appendectomies, and the data was not out there. But it seems like the whole direction was heading there, and it was one of the areas in general surgery that had not been that minimally invasive surgery has not tapped in as a major player. So around that time, I was attending a conference, and I realized that this is going to be a huge new wave, and I need to get prepared for that. So that's when I started to have my first cases in 2008.
Yeah, good for you, visualizing the future. So I guess we can talk about living donor in a second, but one of the things that may help us address is the organ shortages around donation for transplantation, because that's one of the limitations for us as we try and transplant liver patients. So what is your thought with that evolution of donor shortages and living donors, and how do we best help patients find out about it and know that it's a good option for them?
I think there are two tracks in which we can cope with the organ shortage. The first is trying to expand the deceased donor pool. And we also have a very good team there, championed by Dr. Contini, with ex vivo perfusion. So we have that portion to try to have as many deceased donor organs available. Now, on the other side, even despite all of those efforts, there'll still be a huge demand of patients. There's going to be a whole big population of patients who will still be not getting organs to survive. And you just know that, depending on years, but a couple thousands of patients die annually before they get a liver transplant. And I think the living donor liver transplant plays a major role there. As long as the program is run in an ethical way and with enough experience on knowing how to deal with the donors, I think the outcome can be really, really nice. And overall, the outcome of living donor is known to be better than deceased donors. But obviously, we need the sacrifice of the donors. You need the living donors to undergo a big surgery. So one of the things that we are trying to push in Cleveland Clinic is trying to have the donors have a much easier experience donating the organ, which the minimally invasive plays a role in that.
Yeah, I think it's just seeing what you've accomplished is A, impressive, but B, it transforms the recovery of the patient. Instead of having this big Mercedes incision to having a much smaller extraction site and a couple of ports. It reminds me of pelvic pouch surgery or something like that. And
yes.
Yeah, it's been transformational. So maybe tell us a little bit about the preoperative evaluation of the donor, because obviously it's a big operation, giving part of your liver, and how you go into it and understanding the anatomy first, and the mapping and planning that you do is very critical in having good outcomes. So maybe you could explain that a little bit to viewers.
So the donor preparation is the same as for laparoscopic or as in open.
Right.
It's not really that different.
Yeah.
Initially, when we first started the program, we wanted to be a little bit more conservative, take easier cases, because it's still in the developmental stage. When you look at it worldwide, not many people have the experience that we have. and it's considered to be in the developmental stage. But overall, the program for living donor runs in a fashion that all the pre-op workup and it's designed around the donor's safety. So is the donor's good psychologically, socially, mentally, and health-wise as well. And so we do quite an extensive workup on that part. Concerning how we do the surgery, we usually have a 3D reconstruction software that we use. So the liver is reconstructed in 3D form, so we can see the exact anatomy in 3D fashion about the hepatic arteries, portal veins, and bile ducts, and that has helped tremendously improve the safety and also know what we can expect out of the surgery.
Yes, you literally preoperatively will map out the exact precise anatomical sections and areas that you're going to take.
We know exactly where we are heading to before we start the operation, which increases the safety a lot.
Yeah, absolutely. And so then laparoscopically, what kind of instruments do you use to accomplish that? How are you transecting the liver?
So one of the first things that we did, even though I started the program with a 2D scope, I think that a flexible 3D scope gives you a lot more agility to do a better surgery. So one of the things that after I joined our program is establish the platform based on a 3D. And another new technique that is used widely is the ICG technology. So by using the 3D scope, flexible 3D scope, and the ICG technology, we can actually see the process of liver resection a lot better than open surgery, and everything is very magnified. And with the ICG technology, you can see the biliary structure a lot better. So it actually, the complication rate that we have in laparoscopy is, I would say, 4 or 5 times better than in open surgery. We've done until now 22 cases, and we only have one minor complication, just a wound discharge, and no major complication at all out of 22 cases, which, and I think that's the background of having a sound, good support system with 3D scope and an ICG. Looking at the way we transect the liver, we usually use harmonic instruments, ultrasonic shear, for easy places. But for the deeper areas where we can bump into major hepatic veins or the IVC, we usually use a CUSA, which I think it allows us to do much precise dissection, much refined dissection, so that we don't end up having a major bleeding or run into trouble. And I think with that method has allowed us to do all the surgeries with barely like 100 or 200 cc's of estimated blood loss. And until now, we don't have any transfusion as well.
Yeah, and I think the effort you put into structuring it before you actually started doing it, and training and time and equipment, and then all of this planning pre-op and using technology intra-op is the way really to get these excellent outcomes, because it's living donor transplantation obviously is a field where one complication is potentially a disaster for the patient and for the donor for the patient, both patients. So
yeah, actually it took me around 9 months to prepare.
Mm-hmm. Yeah.
It's not only the surgeons, but it's also the scrub nurses, it's the circulating nurses, it's the coordinators. Everybody has to be the same page, know what to expect, and it has to be a seamless flow. The scrub nurses have to know what I want, what I expect, what they on every step of the process. So what we initially did is do many major hepatectomies for cancers, and get the scrub nurses and the whole OR team ready for major liver resections before we embarked on lap living donor. And by the time I realized that I think the whole team was ready, that's when we started doing a lap living donor.
Right. And I think that was absolutely appropriate to do it in that gradual and careful and staged fashion. So it opens up a whole range of other side to the discussion, and that is the potential for the use of minimally invasive approaches for other liver diseases. So obviously, cancer is a big part of that. Maybe you'd tell us a little bit about some of those opportunities for patients.
Before I joined, we used to do barely 30 to 40 cases of lap liver resection, and most of them was just wedge resections. It's just simple wedges. And the penetration rate of laparoscopic or minimally invasive overall was barely in 20%. After all that restructuring of 3D with the 3D scope, with the CUSA on board, and retraining our scrub nurses, we are currently, I think by this year, we'll be doing 100 lap liver resections, and with a penetration rate of above 50%, with a conversion rate of less than 5%. So I think, and it's not only me, my two other colleagues that do a lot of liver resection, they were able to pick in with laparoscopic approach much more comfortably and with a much better outcome. And that, allows patients with cancers or patients with benign liver tumors, they require liver resection, to be able to receive a liver resection. That usually requires at least 1 week of in the hospital with around 2 to 3 months for recovery, and that could be shortened to 4 or 5 days, and about 1 month. Everybody, they are fully recovered.
Yeah, I think it absolutely transforms patient recovery. It really does.
I think you've experienced that with colorectal cancers as well.
Yeah.
So we see the same thing in liver resection.
Yeah, absolutely. So what are your thoughts about where the field is moving in the future? What are the next developments coming along?
Well, I think like major appendectomies now, at least in our clinic, has been routinely done laparoscopically. Some of the fields that we still have to tackle on is like multiple cancers, multiple lesions, because those are more time consuming, and therefore it's really not that easy to do laparoscopically. So we have to sort of like bring up the efficiency a little bit more. And also laparoscopic sometimes can be a little bit ergonomically unsatisfying for the surgeon. So we are hoping to embark more aggressively on robotic platform. Since there has been a lot of changes in the robotic platform, that beforehand laparoscopic had a much better edge compared to robotic when you do a liver resection. With new technology being applied to robotic, I think in near future robotic will be one of the main players, because we have new gadgets that are specifically designed for liver surgery. Just like just one example is CUSA. CUSA is still not available in robotic, but it'll soon be available in robotic in 1 or 2 years coming. And we just want to get ready for the next new wave coming. And with the robotic there, I think we have the chance of doing surgery that requires reconstruction. Most liver resections just requires resection, and we don't do any reconstruction. But like disease like Klatskin tumor or highlight cholangiocarcinoma, which requires extensive reconstruction, I think those will be some of the target patient groups that we can currently only do it open, but in the near future can be done minimally invasive if we apply robotic technology there.
Yeah, I think it's very exciting as we selectively use technology to scale what we can offer and the complexity of the cases, and then just again transform the patient recoveries. Tell me, one of the differences for liver disease obviously is that you often have a larger specimen to take out, particularly if it's right side, than we do with a piece of colon that we can take out kind of end on. So it's through a 3 or 4 centimeter incision. Are there any cases that you can morselize or break up organ to take it out, or are there things coming along around other molecular staging of tumors that'll mean you can fragment specimens, taking them out to improve the short-term outcomes, or is that going to stay where it is now?
Well, for cancers, I think morsalizing, we don't know the stage, so morsalizing will not be there. The liver is shaped in a way, for especially the left side, that is flat and long. So actually removing a tumor that is maybe potentially, let's say 5 centimeters, it requires an incision barely 7 centimeters long. So, that's good. For the right side, we have more limitations. But as of today, I just did a case of hemangioma that is 15 centimeters large. In that case, after you resect the liver, the hemangioma out, you suction out all the blood inside the hemangioma, and I only had to put like 5 centimeter incision to take a 15 centimeter size hemangioma out. So, the benign diseases or the cyst also we barely need to put a small, only a very small incision would suffice to take the specimen out.
Yeah, that's great, because that can make a big difference to them at the end when they get up and move around. Yes. And what about enhanced recovery? How are you mixing in enhanced recovery with these minimally invasive approaches? Are you kind of changing the way you manage the post-operative care of the patients to get them up moving earlier and home as part of it? Is that integrated?
Yeah, so we routinely use tap block or local anesthesia, and along because of the minimally invasive nature of the laparoscopic approach, actually very few patients are under morphine pain medication. Most can do well with just NSAIDs, and with that, usually they can start eating by day 2 in GI soft, and therefore we can the day of admission is decreased 1 or 2 days, because we can speed up the recovery a lot more.
Yeah, absolutely. I think the way you've done it, David, is something you should be proud of. The structure you brought and the effort you put into training the team before rolling out the minimally invasive side of the program to this new level. It's just been fantastic. So.
Yeah, I'm really grateful for the support that the Cleveland Clinic leadership gave to me. I know, let's say, like 3D scope, it's not cheap; they're expensive. But I think by having one of those instruments there actually increases the efficiency of the whole team in a degree that the OR time is reduced, the complication rate is reduced, and therefore, it's worth the investment. And I'm so glad that Cleveland Clinic and the leadership were supportive in that sense, and also glad I'm really thankful to my colleagues who have been really supportive of being eager to learn, because when you first do this, it's really not that easy. It's really very stressful, but everybody was really eager to learn, and I think I'm really glad to say that all of my colleagues are in a level that is uncomparable to any institutions outside within the United States.
Yeah, I think what you are all accomplishing is fantastic. A great team, and the equipment. Absolutely, it's all about seeing what we can do to improve the patient outcomes and help them recover more quickly and better and more safely. And you and your team have done that to a very high level. David, just thank you again for taking time to chat with us today. It's really been inspiring hearing about your vision and the effort you've put in and what you're now able to offer patients. Thank you.
Thanks so much for the kind invitation.